Welcome to this explainer on the procedural journey of a radiographer. You know, a radiographer isn't just someone who presses a button to take a picture. We're actively solving high-stakes anatomical puzzles in real time, and often under immense pressure. Literally, every single millimeter matters. The decisions we make in that X-ray room, they directly inform the life-saving treatments that come next. So, let's explore this incredible journey from the very second a patient enters the room all the way through to evaluating that final, absolutely crucial image.
Here's our workflow for today: ethics and foundation, safety and infection control, patient care and prep, tools of the trade, the art of positioning, and finally, evaluating the final image. Let's get right into it.
Section 1. Ethics and Foundation. This is the invisible framework of our profession.
Before we even touch a machine, we're bound by ALRA, which, as you know, stands for as low as reasonably achievable when it comes to radiation exposure. It's a constant, daily balancing act. We have to get a high-quality diagnostic image, meaning we need enough radiation to actually see what's going on, but we've got to use the absolute minimum amount of radiation necessary to get that job done right. Patient safety is priority number one.
And that ties right into the ARRT Code of Ethics. This code essentially says that we are true patient advocates, not just equipment operators. It demands that we act professionally, respect human dignity, absolutely refuse discrimination of any kind, and rigorously protect patient privacy. Think about it. You're treating human beings, often in their absolute most vulnerable states. They might be in severe pain, terrified, or entirely unconscious. Protecting their dignity isn't just a nice suggestion. It's the mandatory foundation of our practice.
Moving on to Section 2, Safety and Infection Control.
Before making any physical contact, we absolutely rely on standard precautions. These are the CDC's directives based on risk assessment and PPE use to prevent pathogen transmission. Basically, you just have to assume the unseen is present. Whether we know a patient has an infection or not, we operate as if they do. It's this universal approach to risk that stops unrecognized pathogens from spreading like wildfire through a hospital. We are quite literally the front line of defense.
And when you look at the types of body fluids we encounter, it totally makes sense why strict hand washing and PPE are non-negotiable. In a fast-paced trauma or surgery setting, you might run into blood, amniotic fluid, cerebral spinal fluid, or synovial fluid on any given shift. Honestly, there's rarely time to double-check a patient's infectious status when minutes matter, so washing your hands meticulously and throwing on gloves, gowns, or masks is just our everyday baseline.
Section 3. Patient care and prep. Now we bring the human element into the room.
Reading the patient's physical and emotional state is just as critical as reading the technical manual. That's where age-specific competencies come in, organizing criteria for everyone from neonates to geriatric patients. You just can't talk to a terrified toddler the same way you talk to a 75-year-old. For a neonate, you're super focused on conserving their body heat and talking to the parents. For a geriatric patient, you're slowing things down, using positioning aids to keep them comfortable and speaking super clearly. You have to adapt.
And what about trauma patients who literally can't move? We use a structured 6-person patient transfer protocol to prevent severe injury. First, get the stretcher completely parallel to the table. Then, 3 staff members position themselves on the stretcher side to pull, while 2 staff members are on the far side to push. Finally, 1 dedicated person supports the head and feet. Then, everyone lifts smoothly in unison. It's a highly choreographed maneuver, because if just one person lifts off tempo, it could easily exacerbate a delicate spinal injury.
Now, controlling motion is absolutely vital for a clear image. We're dealing with 2 types: voluntary motion, like a patient moving because they're nervous or breathing, and involuntary motion, like a heartbeat or peristalsis. You obviously can't tell a patient's intestines to just stop digesting, right? So we manage involuntary motion using extremely short exposure times. But for voluntary motion, we can use great bedside manner, clear communication, or tools like radiolucent sponges to help them hold still.
All right, Section 4. Tools of the trade. The patient is prepped, so let's look at the hard science.
We capture those invisible X-rays using various image receptors, and selecting the correct computed radiography or CR plate size is a big deal. We've got standard sizes like 8x10, 10x12, 14x14, 14x17, all the way up to a massive 14x36 inches. You definitely wouldn't use a huge plate for a tiny wrist, and you absolutely need the larger ones to capture an entire adult abdomen. Aligning the specific anatomy perfectly to the center of these dimensions is honestly an everyday art form.
To really optimize image detail, we rely on tools like X-ray grids and compensating filters. Grids essentially act like microscopic Venetian blinds. They clean up the messy, scattered radiation before it hits the receptor and fogs up the image. Compensating filters, on the other hand, actually change the X-ray beam itself. Imagine imaging a foot. The toes are way thinner than the dense heel. A compensating filter, like a wedge filter, blocks more radiation over the thin toes and lets more through the thick heel. It perfectly balances the exposure across varied tissue densities.
Section 5. The art of positioning. Let's see how all this preparation builds into mapping precise anatomy.
So, here's a classic puzzle. How do we view the dens without the teeth in the way? You need to clearly see the C1 and C2 vertebrae in the neck, specifically that small peg-like structure called the dens. But the dense bone of the skull and the teeth are completely blocking your X-ray beam. What's the trick?
The answer is the AP open-mouth C1-C2 projection. You have the patient open wide, and you precisely align the bottom of the top teeth to the mastoid tip perpendicular to the image receptor. This perfectly projects the dens without superimposing the teeth or the base of the skull. Talk about a game of millimeters. If the upper incisors project over the dens, the neck is flexed just a tiny bit too much. Base of the skull covering it, extended too much. It takes incredible precision.
We can even use the invisible physics of breathing to our advantage. Inspiration depresses the diaphragm and expands the lung fields. Expiration elevates the diaphragm and shortens them. If you tell a patient to inhale deeply and hold it, it physically pushes the diaphragm down and expands the chest cavity, which happens to be perfect for getting a clear lateral sternum X-ray. We are literally shifting a patient's internal anatomy just by coaching them on how to breathe. How cool is that?
Finally, Section 6. Evaluating the final image. This is where we make sure all our hard work pays off. I love using this fun little parody of Twinkle Twinkle Little Star to help memorize the evaluation criteria for a perfect RAO sternum radiograph. It goes, twinkle twinkle, sternum clear, over heart you must appear. Jugular notch to xiphoid tip, minimal oblique, do not slip. Twinkle twinkle, sternum bright, free from spine, now that's a sight. Yeah, it's a little silly, but it perfectly hits everything the radiologist needs to see. The entire sternum positioned perfectly over the homogeneous heart shadow, totally free from the spine, with just the exact right amount of oblique rotation.
And when we're examining a lateral cervical spine image, we're looking for 4 parallel lines indicating healthy alignment: the anterior vertebral line, the posterior vertebral line, the spinal laminar line, and the posterior spinous line. These 4 distinct lines absolutely must follow a smooth, natural lordotic curve. Any break, disruption, or step off, that immediately indicates a severe bony or ligamentous injury. This is exactly why our positioning and immobilization techniques have to be flawless. A single millimeter of misalignment, or even just a zipper accidentally left in a pocket, can mean a misdiagnosis that alters someone's entire life. So, are you ready to master these steps and be that critical diagnostic partner? I hope this explainer has shown you just how vital this role really is. Thanks so much for tuning in, keep learning, and stay curious.